The meninges and meningeal spaces, we discussed during the last lecture that there are coverings around the brain. Between the skull and the brain, there are 3 coverings which are called meninges. And these meninges, if you name them, they are Dura mater, arachnoid mater, and pia mater. When it comes to the Dura mater, we said that the Dura mater is attached to the skull. You have the skull on this side. Dura mater is attached to the skull. On the other hand, pia mater, third one, it is attached to the surface of the brain here. And I said the pia mater, the attachment of pia mater should be understood like the attachment of visceral pleura to the lung. So if you want to separate it from the brain, you have to tear it from the surface of the brain. That's what you do with the visceral pleura of the lung also. You have to tear it from the surface of the lung. It's just like that. So remember that point. Then we also said that there are ventricular spaces, cavities inside the brain, lined by ependymal cell layer. We discussed it. So then we said, okay, now then these things, okay, if I take this one, if you first discuss about the Dura mater, Dura mater has 2 layers. At least we describe 2 layers. It's actually one layer. It's one layer like this. In certain places, like where you get dural venous sinuses, the layer gets separated out into 2. So one layer goes like that. Other layer gets separated out. Remove this. So then, like this, okay, they get separated out, like in this diagram you can see. Now here, therefore, now this is the dural venous sinus. You get venous blood in this one. Okay. So here, now even though you don't see that, here you see it as only one layer. Okay, Dura mater. But here you see 2 layers. One layer here, another layer there. Your skull is here, in that layer. So then, because of this, you name 2 layers. One on the side of the skull is called endosteal layer. Then one on the side of the brain is called meningeal layer. So this is how you divide the Dura mater into 2 layers. So then if you look at this diagram, which I got from internet, you can see a few things in this diagram. Now you see the skull outside here. You see the skull outside here, which has 2 layers on either side, pericranium, and inside you get the endocranium, pericranium and endocranium. And this endocranium is none other than this endosteal layer of Dura mater. That's what it says, Dura mater here. Okay, so it is when we define Dura mater as having 2 layers, the endosteal layer is actually the endocranium of the vault of the skull bone there. If you look at the skull bone itself, this is how you see it in a diagram. You see 3 layers. You see what is called outer table here. You can read it here. Okay, outer table of compact bone. I think you have studied bones, compact and spongy bones. So outer table of compact bone and inner table of compact bone. So there are 2 tables, outer table and inner table. Then in between you get spongy bone. In between you get spongy bone. Now when it comes to fractures of the skull, you can have fractures of the outer table of the skull, or you can have fractures of the inner table of the skull, inner table alone or outer table alone, or you can have fractures throughout. Okay, so it's outer table, inner table, as well as the middle part, of course. Then if the fracture is only in the outer table, here, the risk of bleeding inside the cranial cavity here, in that area, is not there. Okay, because whatever the bleeding will be to the outside. If you have a fracture of the inner table or a complete fracture, then there is a risk of bleeding into the cranial cavity because there are blood vessels. We'll see in a moment. There are blood vessels very closely associated to the inner surface of the skull. They are actually under cover of the endocranium or the endosteal layer of dura mater. So this is the point that I wanted to raise. So remember this point. Then when you talk about skull fractures, now if you have learned about the scalp, you have scalp. You have to have a C here. SCALP. Scalp. Now scalp means, it's 3 layers. You have the skin here, then you have the connective tissue layer, you have an aponeurosis, then you have a loose areolar tissue layer and a pericranium. Pericranium is this one. Okay. So this now this when you say, if you receive a hard blow to your head and if you get bleeding, usually what you get is lacerations of the scalp. You call it scalp laceration. So when we say you have a scalp laceration, that does not mean that you always have a fracture of the skull here. Okay, only rarely you get skull fractures. Commonly you get scalp lacerations. Since the scalp is fairly thick, people think that it is the bone that got fractured. Okay, but it's not the case. Usually it's the scalp that get damaged due to injuries, not the bone. But when the bone gets damaged finally, then you have a risk of bleeding into the cranial cavity. So that is the issue with the scalp lacerations and the skull fractures. So remember that point as well. Then about the dura mater. Now we mentioned during the last lecture, that there are several extensions to the dura mater, like falx cerebri and tentorium cerebelli. Okay, you have the tentorium cerebelli here between the cerebrum and the cerebellum, and the falx cerebri between the 2 cerebral hemispheres. Now then we said the tentorium cerebelli is something like this, attached to the petrous temporal bone and the occipital bone here. So above that you get the cerebrum, and below that you get the cerebellum. The brain stem passes through this opening here. Okay. Then when you produce this falx cerebri and tentorium cerebelli, what happens is, if this is your dura mater, you get, as we said, the 2 layers get separated out here like this, and the inner layer or the meningeal layer is the one that goes down. Okay, meningeal layer is the one that goes down, forming the falx cerebri. Endosteal layer remains attached to the skull. So you get blood in this space. Actually, when it comes to the falx cerebri, you have another opening here between the 2 meningeal layers. So that this one is called superior sagittal sinus. We will discuss this later. This one is called inferior sagittal sinus. Okay, and even here at this edge, in this edge where it is attached here, and in this edge where it is attached to the bone, it gets separated out like this. Okay, in both these places, forming dural venous sinuses. So here also you get a opening like this. Okay, laterally, that is this one. Okay, so because of these 2 layers, so remember that point. Then meningeal spaces, which is an important concept again, meningeal spaces. Now there are 3 meningeal spaces: extradural space or epidural space, subdural space, and subarachnoid space. Now extradural or epidural space means a potential space. You don't see a space in the living issue. If you look inside the cranial cavity, you take a section and see, you don't see a space, but it's a potential space. If you introduce something, then a space will open up in this area. So that is between the skull and the dura mater. So here, when I say dura mater, it is the full dura mater. Okay, it's actually the spaces between the endosteal layer of dura mater and the inner table of the skull. Okay, endosteal layer, inner table of the skull. So I have written it here, inner table of the skull and the endosteal layer of dura mater. So that space is outside the dura mater, therefore you call it extradural space, or it can be called epidural space, same meaning. Then there is another space, there's another space between the dura mater and arachnoid mater. So that is here. That is also somewhat like a potential space. That also can be opened up if you introduce something into that space. So that subdural, that is called subdural space. Why it is called subdural space? Because it lies deep to the dura mater. Okay, but it lies between the dura mater and arachnoid mater. Then the third space is the subarachnoid space, which lies deep to the arachnoid mater. In other words, it lies between the arachnoid mater and pia mater. Arachnoid mater and pia mater. So you see the pia mater attached to the surface of the brain here. Now, when it comes to the subarachnoid space, that space is, you can't call it a potential space because it's actually there, a visible space exists there, because you get blood vessels passing through that space, and this space is filled with cerebrospinal fluid. So it actually contains certain things. And these bands in the subarachnoid space that connect the arachnoid mater to pia mater are connective tissue, so softly, loosely arranged connective tissue bands. So whatever that passes through it, CSF or blood, has to pass in between these connective tissue strands. So remember these points. So there can be bleeding into these spaces. So later we will discuss that. You can have bleeding outside the dura mater, which is called then extradural hemorrhage. You can have bleeding into the subdural space, you call it subdural hemorrhages. You can have bleeding into the subarachnoid space, you call it subarachnoid hemorrhage. We will discuss these things later. Then this is a section of the scalp here, and the skull, and the meninges. You see the dura mater here and arachnoid mater all close together. You can't separate them out. Your pia mater is here, and this space you can clearly see that this space is the subarachnoid space. You see these connective tissue strands as well as blood vessels in that space. Okay, so the blood vessels run through that space. Run through that space, and the blood vessels, when they run through that space, they are bathed in cerebrospinal fluid, because that space is filled with cerebrospinal fluid. And the other thing is the space, subarachnoid space, since the pia mater is attached to the surface of the brain like this, it dips down into the sulci. So subarachnoid space continues down into the sulci like this. Okay. So if we introduce something into this space, even CSF is there in these spaces. So if you introduce something like blood, they will go down into sulci here. Okay. So as I said, this space is filled with CSF, and you have the blood vessels also there, as you can see in this image. And the other thing is, you can, since cerebrospinal fluid is there, if you want to take cerebrospinal fluid out for investigations to check it, you can take it out, but not in all places. Especially you do it in the spine, okay? In your lower part of the vertebral column, where there is no spinal cord. So that is called lumbar puncture. I'll talk to you about lumbar puncture in a moment. Then the other point is, in case there is bleeding into this space, subarachnoid space, from the blood vessels in that space, then you can understand that the blood and CSF will get mixed. Okay, CSF gets mixed with blood because it's the same space. So this entering the subarachnoid space to collect cerebrospinal fluid, very small amounts. The principle behind this is that the length of the spinal cord, if you take a child or an adult, the length of the spinal cord is less than the length of the vertebral canal. Okay, now you have the vertebral column and the vertebral canal inside. length of the spinal cord, which is inside the vertebral canal, is less than the length of the vertebral canal. Now, if you look at an embryo, fetus at 3 months, fetus at 3 months, this is how you see it. Now, this is how you understand the diagram. This black line, you can see a black line that represents the dura mater and arachnoid mater together. Yeah, black line indicates dura and arachnoid together. Pia mater is indicated with blue line. Okay, pia mater is indicated with blue line. So the orange area, orange colored area is actually the subarachnoid space. Now, if you look at the fetus at 3rd month, the subarachnoid space, the orange colored area you can see here, orange or red, whatever you want. It's a very small space, limited only to the gap between the pia mater and the arachnoid mater there. So the whole vertebral canal is filled with spinal cord shown in yellow color here, spinal cord. So it comes down all the way to the lower part of the sacrum, spinal cord as well as the meninges. But at birth, during the fetal life, there's rapid growth of the vertebral column. With that, you get the lengthening of the vertebral canal, the development of the growing in length of the spinal cord cannot keep in pace with the growing in length of the vertebral column. So what happens is in a newborn, in an infant, the spinal cord is shorter compared to the length of the vertebral canal. So it ends somewhere at the L3 level. Okay, somewhere at L3 level, as you can see here. Okay, so below that you get a space, fairly large space of subarachnoid space. That space is called lumbar cistern. Okay, so this enlarged spaces in subarachnoid space are called cisterns. There are cisterns in the cranial cavity also. I'll show you some of them. So here also you get a cistern opening in the subarachnoid space. You call it lumbar cistern. Now, when you grow into adults, the situation is different again. There is further relative shortening of the spinal cord. Further relative shortening of the spinal cord. By now, you know that in adults, spinal cord ends at the level of the lower border of L1 vertebra. Okay, so you have a fairly large lumbar cistern, subarachnoid space. If you want to draw cerebrospinal fluid out from the subarachnoid space, you cannot enter needles in these places because you get the spinal cord inside, you will damage the spinal cord and you will get all sorts of problems. So what you do is, whatever you want to do, you enter the needles if you want to take CSF out below the level at which the spinal cord ends. Okay, so in an adult, the safest place would be between L4 and in an adult, actually you can go here, L3 and L4. Now in an infant, since the spinal cord is relatively long compared to an adult, it's better to try L4 and L5. You can understand it. But sometimes you can't do it in the first attempt. So then if you fail it, it's not recommended to go again because there's blood and all in that area. So even in an adult, you may try the upper space L2 and L3 as a second attempt. Okay. So in infants, you don't have many options. If you go here, the risks are very high because the spinal cord just ends there. Okay, so you can have a slightly longer spinal cord in an infant, so you can't take a risk. Now, why you don't go here? You might think, why you go up? Why not here? Or why not here in an adult? Because the thing is, the lower you go, then the chances of you getting into the space is less because it's a process of bending and going in. So you cannot bend this part of the lumbar spine too much. But if you go up, when you go up, the bending is easy. Okay, when you go down, bending is difficult. Okay, so that's the very practical reason. That's why you have to balance between the possibility of bending and the possibility of not damaging the spinal cord. So this is how you do it. Not that you have to do it now, but when you go to wards, you will at least see it. So you bend the person like this, so that the distance between the spines is more when you bend forward like that, so that you can easily send a needle through the skin, supraspinous ligament, interspinous ligaments, and then you go through the dura arachnoid and dura majus and enter the subarachnoid space. So this green here indicates the cerebrospinal fluid, not the spinal cord. Okay, you can't do lumbar puncture where there is spinal cord. Then you can do the same thing when the person is in the sitting position. You can bend and do it from the back. Okay. So just remember it. So in adults, usually you go between, the first attempt is usually between L3 and L4. If you fail it, you go one space above. Okay, between L3, L2 and L3. But in infants, you go one less, between L4 and L5, because their spinal cord is relatively long. Okay, just remember it. Then there are risks involved with lumbar puncture. Even though I'm not talking about lumbar puncture here, just know that also. Now, just think of it. Now, you are going to remove some fluid, maybe half ml or something. Even though it's very little, you don't get much CSF anyway in this space, the very small space. So if you remove some fluid from that area of the subarachnoid space, supposing that you have high pressure here in the cranial cavity. Okay, if your intracranial pressure is high due to some reason, say head injury or a tumor inside the brain, if the intracranial pressure is high, you never do lumbar puncture, because once you remove some fluid from here, the pressure drops in the lower part, and the brain parts of the brain tends to herniate through the foramen magnum here. Okay, and the person can die. Okay, or have serious complications. So you call it contraindications. So raised intracranial pressure is a serious contraindication for lumbar puncture. Know that also. Okay. Then this issue about subarachnoid cisterns, the concept of subarachnoid cisterns. So lumbar cistern is the one that we frequently use to draw CSF. Then you get these subarachnoid cisterns in the cranial cavity. There is a long list of subarachnoid cisterns. You don't have to remember them in that way, but remember the concept. Now, there are a few of them. Cisterna magna. You call it cerebello-medullary cistern also, because they are between the cerebellum and the medulla. Then you get another cistern here in front of the medulla. You can call it medullary cistern or premedullary cistern in front of the pons. You call it pontine cistern or prepontine cistern. Then you have an interpeduncular cistern. You get the midbrain here. You get the cerebral peduncles of midbrain here. So this is in front of the cerebral peduncles of midbrain. You call it therefore interpeduncular cistern. Then behind the midbrain, you have another cistern called superior cerebellar cistern. Superior cerebellar cistern, because it's above the cerebellum here, that space. Okay. So these cisterns, they in a way they act as cushions because it's filled with cerebrospinal fluid. So when there is shaking or a blow to the brain, then it has a cushioning effect. And the other thing is, if you look in these spaces, usually you get why this space has been created. The reason is that you get now here, for instance, you get the vertebral arteries, okay, coming to that side from the back side. Then here you get the basilar artery, and there are cranial nerves passing through these areas. So there are things like that happening in these cisterns. Okay. So remember this point as well, but you cannot remember the names of all the cisterns. We don't expect you to do that. Then the other point is, now yesterday I said, when I talked about the ventricular system, I said the cerebrospinal fluid, which is usually produced inside the ventricular system, lateral ventricles and the third ventricle, they are released into the subarachnoid space from the roof and the sides of the fourth ventricle. Here, this is the fourth ventricle, through two foramina. Now, one foramen is called foramen Magendie. Foramen Magendie. So that one actually is here releasing CSF into the cisterna magna. Okay. Then you have this other foramina, two foramina of Luschka, and they release CSF from fourth ventricle into the pontine cisterns. Okay, so somewhere here. Okay, so think of it like 3D. Okay, so then this is how the CSF circulation completes. So CSF comes into subarachnoid space and gets absorbed through the arachnoid granulations in these areas into the superior sagittal venous sinus.